All right, so I think Dr. Dolly already pointed out to us that anxiety is extremely common in kids with autism and with intellectual disability. In autism specifically, we see that prevalence of any anxiety disorder around 40%. Again, there's a lot of debate. Is this just part of the autism or is this something comorbid? And again, we're just really talking about a cluster of symptoms here. And when I say anxiety disorder, it can mean a lot of different things. So we do see kids who will sometimes fit that classic DSM-5 definition of something like a phobia, a generalized anxiety disorder, social anxiety disorder. But more often than not, I would say we see this sort of atypical presentation that's more consistent with autism. And I'll talk a little bit more about that in the next couple slides, but that means things like anxiety around transitions, trouble tolerating change, fear of things that are new or unexpected, or even anxiety around certain sensory experiences, loud noises, unexpected touch, things like that. And that's probably more commonly what we get referred and what we're treating when we say anxiety and autism. So not always does anxiety map neatly onto these DSM categories, and I would probably say more often than not, I'm just kind of coding general anxiety with autism as my primary diagnosis. We do see some association between anxiety and IQ. So what we see is as with higher IQs, we tend to see more anxiety. Now, is that because they're better able to report those symptoms to us, or they're more aware of their disability and that creates some anxiety is up for debate. So here again, we see a lot of overlap between autism and anxiety, and we talked about some of these already, but you could think about some of the core criteria of autism as anxiety symptoms. So again, that trouble tolerating change or deviation from routine, this insistence on sameness and anxiety when things are not the same. There's some overlap there between ASD, anxiety, OCD. We see a lot of discomfort in social situations and these sensory experiences. So this is a graphic that's just meant to illustrate all of the different things that might make somebody with autism more prone to having anxiety. We see this extreme sensory sensitivity. So if you're always hyper alert or hyper vigilant to your environment, that can be a very anxious, anxiety-provoking condition. Communication impairment. I always think, trying to put myself into the position of this child who's having trouble communicating, how much anxiety that in itself would create, not being able to have an effective means of communicating my feelings or my internal states or my needs. We see very real problems with social rejection or social skills deficits leading to peer rejection. That in itself can be a source of anxiety. We see this inherent difficulty tolerating unpredictability, trouble with changes, and we also see executive dysfunction in cognitive patterns that can really lead to some anxiety. So if you expect things to be one way and it's hard for you to shift your thinking to another way of thinking, it's going to be hard to problem solve, and it's going to create some worry when things don't go the way you think that they ought to. Just a bit about social anxiety. So we think about autism as it's defined as a definition, by definition, a problem with social communication. But what we also see is that even in addition to that, some kids have a high level of anxiety when they're interacting with other people. And that's in part due to these inherent difficulties understanding social cues and social information. But there's also this group of kids, perhaps kids who have an average IQ or above, who are really aware of how their peers perceive them, and I think that is a risk factor for social anxiety. We also see that kids have this sort of hyperarousal that might contribute to social anxiety as well. So this I think of as distinct from lack of interest, right? So there are some kids with autism who have a high level of social interest, but they're awkward in their approach, and that creates some anxiety. So here's what we recommended last time. We have our comprehensive assessment, which we'll talk about.
Anxiety, right there on top.
Oh, yeah, this print, 2017 ADHD.
Oh, I did. Sorry, this is anxiety. My bad. Yes. Thank you for that. So we have level 1 is again comprehensive assessment. Level 1, we have our psychosocial non-medication interventions, treatment of comorbidity. Our level 2 recommendations were sertraline, fluoxetine, or Buspar. We'll talk a little bit about that. Level 3 is getting your consultant involved. Okay. So what do we think about when we're doing our initial evaluation? Well, so what we wanted, I think about anxiety is, again, spanning a couple different categories. So I'm asking about things that are specific to autism, like tolerance of change and sensory differences, but also some of the more classic anxiety symptoms like fears and phobias and social anxiety. I see a lot of fears and phobias in particular around things in the environment that are difficult to control or unpredictable. So that is often things like insects or fear of shots and needles or fire alarms. So things that could happen unexpectedly that could create some anxiety for those kids. As with everything, we want to focus on ruling out a possible medical cause, particularly in kids who are less verbal. So if we have a kid who's presenting suddenly with anxiety or agitation, we want to look for any sources of pain or discomfort. We want to think about whether there could be a condition like hyperthyroidism that is presenting in a behavioral way, or a side effect of a new medication. And I don't think hyperthyroidism is necessarily more common in general ID or autism, but in certain categories of disability. So in Down syndrome, we see a lot of thyroid abnormality, and now I've seen a couple of cases of kids presenting with agitation that turned out to be hyperthyroidism. So that's why I include that there. Because our medication choices are, as you'll see, fairly limited, we're always thinking, what else can we modify that might reduce anxiety in this child's world? So are they having learning difficulties that need some intervention? Is there a way of intervening if they're being mistreated or bullied at school? Can we help this family create some more structure or some more routine to their home environment that increases their sense of predictability and decreases their anxiety? We're thinking about ADHD and depression. These are things that both might go hand in hand with anxiety, but also might influence what kind of treatment and how we're ordering our treatments. So for example, in a kid who has symptoms of anxiety and ADHD, we might be very cautious about using a stimulant out of concern that we might be worsening their anxiety at the same time. And then part of my initial evaluation is always to think about cognitive level, because that will also help inform what sort of non-medication treatment options we're going to recommend. So a kid who's fully verbal with an average IQ might be a good candidate for CBT. Somebody who is nonverbal is not going to benefit very much from CBT, but might do great with ABA. Okay. So the best evidence for our treatment of anxiety and autism really comes from non-medication interventions. It's really focused on modifying the environment and managing symptoms of anxiety. So we see sensory defensiveness as a pretty common element of anxiety, and there's a lot of behavioral and environmental modifications that we can make to reduce that. That can include things like noise-canceling headphones when you're at a noisy outing. That can be occupational therapy. That can be avoiding situations that are known to be overstimulating, like crowded and noisy places. For trouble tolerating change, we try to increase the level of predictability in the environment and help kids preview and understand what to expect in a certain situation. That can be with social stories. That can be with picture schedules or written schedules. That can be using things like transitional objects. So you'll notice there's a lot of emphasis here on visuals, so kind of playing to their strengths, which is often in the visual spatial domain, so kind of giving more information in a visual way. So where is the evidence? I mean, this is sort of what we have best evidence for, specifically for anxiety and ASD. There's a lot of information out there to support CBT being helpful for some kids, and often it's going to need to be modified in certain ways. So the main adaptations are having a strong component of social skills to help with increase their success with their peers. It may need to be adapted for language impairment and for cognitive ability. And what we generally find is that parents need to be more heavily involved than you might for average CBT for a child with anxiety. So I'll talk just a bit more about that. The core components, this is not unique to CBT for ASD, but it should involve psychoeducation about anxiety. It should involve cognitive strategies and then behavioral strategies. But there are some specific protocols out there that are designed for use in autism. And if you can find somebody or a group who does these, I think even better. I'm sure that they're few and far between. I know they are where I live, but if you can find them, these have some evidence behind them. And all of them do have a parent component, and they have some social skills instruction built into the CBT. All right. So this is kind of shocking given how common it is, but there's no published clinical trials specifically of medications for anxiety in autism. And that was true in 2017, and that is still true now. So this is a very underdeveloped area of research. There's probably some good reasons for that. One is that high degree of symptom overlap and our lack of good measures for parsing out anxiety from autism. So one of the criticisms of a trial might be that how do you know what you're measuring is actually anxiety and not autism? We don't have good outcome measures. There's limitations of self-report for a lot of children with ASD, and so it's hard you have to kind of assume an internal experience based on outward behavior and parent observation at times. And we don't have any good biomarkers to help us differentiate treatment response. We're really reliant on self-report and parent report measures. And there's a lot of susceptibility to placebo effect and bias in those. Okay, so not much new since 2017. There is one paper out there that is a chart review of buspirone in 31 children who had high-functioning autism. I find this is a fairly high mean dose, about 40 milligrams a day. And in this chart review, and again, remember, this is sort of treatment as usual, about 60% or so were rated as a 1 or 2 on the CGI, which means that they were much or very much improved as rated by their clinician. And then another third were rated as mildly improved. So we saw improvement in their overall functioning. The people who wrote the paper found that it was well tolerated. There were not a lot of adverse events. There were 2 children who were more activated and had some mood lability. So this, I just wanted to go back to one study of buspirone that we talked about last time. This was published in '98. This was another open label study, 22 kids this time. And it wasn't specifically meant to study anxiety, but it was defined by, the parents were defining a target symptom. And for 14 of those 22, it was anxiety, but there was also irritability and irritability plus anxiety in that mix. They did find about a third of them, or a little bit more than that, improved overall, and that it was well tolerated. And then there was one RCT of buspirone, but anxiety was not their primary outcome measure, it was a secondary measure. So what they were looking for specifically was improvement in repetitive behavior, and the ADOS was actually their primary outcome. But they included some secondary measures and did see some improvement in what they created was this anxiety composite that took a couple of different scales and combined them. I don't know what to make of this. They did find some improvement in these young children at lower doses, but at the higher doses did not separate out from placebo. So kind of mixed data. So here's what we have if we were going to put all of that together. For buspirone, and this is just, again, specific to autism, we have 2 case series, and we have 1 secondary RCT data. So I gave that a recommendation of B, which is sort of the, the best that we've got here. And that's how that came to be included in the same category as things like fluoxetine and sertraline. We don't have any studies that have specifically studied anxiety for fluoxetine and sertraline. So a lot of what we're doing here is extrapolating from pediatric anxiety literature. And we're finding that there are certain things that have some evidence of benefit in that group, and using that to inform our decisions here, with the understanding that there might be some important differences in response rates that we're not aware of. There have been studies of fluoxetine in autism, specifically looking at repetitive behavior, and we'll talk about that in another talk, but as far as anxiety, not so much. Benzos, there are no studies. We don't generally recommend them. A lot of these children can have paradoxical responses, like you can see with things like Benadryl, where they seem more agitated rather than less agitated. We also don't have any literature from pediatric anxiety to rely on here either.